I'm going to talk this morning about, looking at open versus robotic radical cystectomy. So first question is, how do you define the quality of a radical cystectomy? Well, you look at oncological outcomes, positive soft tissue margins, the extent of lymph node dissection and survival, estimated blood loss and transfusion rates, operating time, perioperative complications, inpatient stay, cost, and long-term complications and quality of life. So this data very clearly shows the impact of positive surgical margins on patients undergoing cystectomy. This is from SWOG 8710. You can see the catastrophic outcome for patients who had a positive surgical margin. These patients are all dead by 2 years. Another a variable that's been said to be prognostic is the extent of lymphadenectomy in patients with lymph node negative disease. And these are 3 papers that came out in the early decade, and you can see this is data from Harry Herr showing that patients who had at least 8 lymph nodes dissected had a better survival than those that had less. Of course, there's lots of bias in these types of retrospective analyses. This is actually a review of SWOG 8710. And the median survival for patients undergoing a standard dissection was 7 years, a more limited 4 years, and no dissection at 2.4 years. But you can imagine there are reasons why the patients did not undergo a lymph node dissection. Now, this is results from a randomized trial performed in Europe. And they're looking here at cancer-specific survival for patients undergoing an extended and limited lymph node dissection, and there's no difference in the cancer-specific survival. Similarly, there was no difference in the overall survival between those individuals who had undergone an extended versus a limited node dissection. If you looked at morbidity, the only adverse event that was higher in patients who underwent an extended lymph node dissection was the 90-day incidence of lymphocele requiring drainage. That was higher in those patients undergoing an extended lymph node dissection. No other factors popped up. Now, there's a lot of factors that can impact the number of lymph nodes that are resected. Obviously, the extent of the lymph node dissection, but also, the specimen can be divided into packets, according to location by the surgeons in order to increase their count. We know it also depends on the pathologist and also their patient considerations as well. Now, it's also been shown that surgical volume is associated with outcomes. This is data from SWOG 8710 again, showing that the survival of patients whose surgeon contributed more than 5 cases to the trial did better than those patients whose surgeons put on less than 5 patients. And this is data from Texas. This Linda Eltiger, who's an epidemiologist at MD Anderson, put this together, looking at Texas inpatient mortality rates for high, moderate, and low volume hospitals after radical cystectomy. And you can see the dramatic decrease in mortality in the high volume centers. There was only actually 2 high volume centers at the time. And this also translates to higher costs. You can see that for healthy patients with comorbidity, the cost of cystectomy was reduced in the high volume centers. That's sort of counterintuitive, but that was the case. And I guess that's because it's expensive to die in a hospital after a radical cystectomy. Now, this is our complications of radical cystectomy. It's retrospective data. Rob Zvatek published this in 2009. Our overall complication rate was 54%. Major complications in 20%. Major complications would include things like PE, MI, and stroke. And the major predisposing factor for a complication was the BMI. In the time frame of which the study was conducted, there was no perioperative mortality. And if you looked at the number of complications per patient, in those patients that had a complication, 55% had multiple complications. This is data coming around the same time from the City of Hope, who had one of the largest robotic cystectomy cohorts at the time. And again, their reports on complications were very, very similar to what we reported as well in our retrospective study. So what about the randomized trials? So this is a meta-analysis of 5 randomized trials comparing robotic versus open cystectomy. And what did they find? They found no difference in oncological outcomes, adverse events, or quality of life. Robotic cystectomy was associated with less perioperative blood transfusions and a shorter hospital stay, but a longer operative time. And the caveat was in these studies, these are early studies, that all of these diversions were done open. This is the the paper that Arnav referred to yesterday. This is a randomized trial with intracorporeal diversion carried out in Britain. So this is a randomization of patients undergoing a robotic cystectomy with intracorporeal diversion versus an open cystectomy. And they're looking at the 90-day morbidity and mortality rates. That's a bit misleading if you look at the data. So this is their primary endpoint. They reported that robotic cystectomy resulted in a statistically significant increase in days alive and out of hospital within 90 days of surgery than open cystectomy, 80 versus 82, and that was significant. That doesn't mean that those patients had a morbidity, doesn't mean they died. It just means they spent, in the first 90 days, they spent 2 more days in the hospital. There's no significant difference in 12-week complications or mortality, no differences in quality of life, no differences in cancer recurrence or all-cause mortality, and even the authors admit that the clinical significance of their findings is uncertain. In fact, I presented this at the SIU, where one of the authors was chairing the session, and he agreed with that. So then I thought about looking at our own MD Anderson experience. This is sort of a fun study. This was a study done very early, looking at the quality of the robotic lymph node dissection at MD Anderson. So patients underwent a robotic cystectomy and a bilateral pelvic lymph node dissection by one surgeon, followed by an open completion of the lymph node dissection by a robotic surgeon, and an open completion by one of 3 open surgeons. So 93% of the lymph nodes were removed robotically. That's pretty good. And again, they're really good at taking out the external iliac, the internal iliac, and the obturator nodes. But there was not quite as good as dissecting out the right common iliac, left common iliac, presacral, and para-aortic or caval lymph nodes. I have to admit, though, that the quality of the lymph node dissection by robotic surgeons has improved since then. So this is a slide I want to show you. This is one of my patients, and this is the patient after a robotic lymph node dissection. You can see the nodes in the para-aortic and internal iliac are left behind, and this is the completion after open completion. So I like showing that slide to the robotic surgeons. Although I realize that it's dated, but it's still fun. So we looked at our own data comparing open and robotic cystectomy. This work was done by Janet Kokretcha, who's now working in Colorado, and Nima Navai, who's our robotic surgeon. They're determined to show the benefits of a robotic cystectomy. Now this experience, it was from 2005 to 2015. It predated ERAS for most of the open radical cystectomy data. There was no difference in demographics, no difference in sex, BMI, ASA, or clinical stage in between the 2 groups. More patients in the robotic arm received neoadjuvant chemotherapy, but I think that reflects the fact that it's a more contemporary series. And most diversions were done intracorporally. So what did we find? We found no difference in the overall 30 and 90-day mortality, readmission rates, or overall complication rates. No differences in margin positivity, extended lymph node dissection, patterns of recurrence or survival. Blood loss, transfusion rates, narcotic use, and length of stay were lower for robotic cystectomy, but operative times were longer after robotic cystectomy, and it was more expensive. And again, this did predate our ERAS for most part of our radical open experience. So we introduced ERAS, enhanced recovery after surgery in 2014. So we actually, geriatric patients have needed underwent preoperative evaluation and prehabilitation. We gave patients a carbohydrate-rich diet prior to surgery. We eliminated bowel prep, except for patients perhaps who had radiation therapy or multiple pelvic operations. And we used Entereg preoperatively to stimulate the bowel activity post-op. We used liposomal bupivacaine or Expartil intraoperatively injected the fascia for pain control. We tried to get patients up in a chair on day 0 and fully ambulatory by day 1. So clear fluids administered on day 1 with resumption of regular diet on day 2. We tried to avoid narcotics as much as we could. We used celecoxib and tramadol as needed for pain and aimed for discharge on day 3 and 5. So we did find with ERAS that we did narrow the gap in the length of stay. You can see in the pre-ERAS era, the average length of stay for open cystectomy was 9.4 days. This was reduced to 7 days, so 2.4 days less. And for the robotic patients pre-ERAS, it was 6.6 days, reduced to 6 days. So the difference went from 2.8 days robot versus open to only 1 day, a difference in time of stay in the hospital. And also, we saw a dramatic decrease in the use of narcotics. This is the use of a PCA pump, pre-ERAS, and you can see how we've eliminated that post with ERAS. Now, Janet and Nima were still determined to show that there was a benefit of robotic over open cystectomy, and they felt they would show the cost effectiveness of robotic cystectomy, and they did a complicated statistical analysis, a decision analytical model to compare the health-related quality of life and medical costs for patients undergoing robotic cystectomy with intracorporeal diversion versus open cystectomy. Again, at the same time point, 2007 to 2015. So propensity matching yielded 100 robotic cases, 96 open cases. All of the clinical data was loaded into the model from the charts, and the metric they're looking at, the quality-adjusted life years, which combines mortality and morbidity into a single metric on a scale of 0 for death to 1 for perfect health, was derived from the literature. So they did the analysis, they put all the clinical data into the model, and what they found was that a robotic cystectomy was $17,000 more expensive than an open cystectomy, but it was associated with an increase of 0.32 quality-adjusted life years. So compared to open surgery, the robotic surgery cost about $3,000 less per quality-adjusted life year, and would be the preferred strategy if a complication could be prevented 74% of the time and a transfusion 70% of the time. Well, the transfusions have been prevented, but the complication rate was 47% for both open and robotic surgery. So robotic surgery is not yet cost effective. So just to summarize, if you look across series, there's really no difference in cancer-specific outcomes. The extent of lymph node dissection, positive soft tissue margins, or survival between open and robotic surgery. There's less blood loss, less analgesics, and quicker to diet following a robotic approach. But the differences in length of stay and analgesic use have been minimized with ERAS. There are longer operative times and higher costs with robotic cystectomy. No difference in 90-day complications, quality of life, or survival. Robotic cystectomy would be cost-effective and the preferred approach if the complication rate could be further reduced. But I have to, and right now, with respect to which is better, it's really surgeon dependent, because just like a world-class athlete like Roger Federer or Tiger Woods, experienced surgeons rely on muscle memory. So the jury is still out, and who are you going to bet on? Thank you.